My name's Tony Levitas, and I'm a senior fellow here at the Watson Center. And it's my great pleasure to introduce an old colleague and a dear friend, Rebecca Black, to talk about the U.S.'s role in global health policy. Rebecca graduated many years ago, we won't say when, from the University of Michigan's Political Science Department, did an MA in urban planning at MIT, was then deeply involved in community development work in Boston and its environs, and served for 6 years in the community planning department in Boston, so much so that there is a Rebecca Black Day named for her by Mayor Flynn, and joined USAID in 1992. Her first posting was in Poland in 1994, and that's where we met, and her portfolio then was urban governance. And I'll wager that that's still her first love, but as she moved on in the aid world, working in South Africa, India, Afghanistan, before becoming mission chief in Mali and then Cambodia, she became more and more involved with health issues because fully half of USAID's overseas budget is typically engaged in health. She has recently retired from USAID and is looking now for new ways to be involved from the outside. And with that, I'll turn the floor over to Rebecca.
Thank you very much, Tony. It's a great pleasure to be here, especially with young people. I think I was, one thing about, I live in New Mexico in a community that's relatively old, so it's great to meet a lot of young people. And with Tony, who I've known for a long time, and with Pat McGuigan, who happens to be in the audience, who I worked with in Boston. So like community development world and my international world. So I'm a bit traumatized because of the rain. I've been living in desert climates for about 15 years, so this is a bit different, this chronic drizzle. So this really was asked to talk about the U.S. government and its role in global health, sort of what's happened in the past. It's a good story. In large part, there's been tremendous improvement in many of the health statistics over time. As you see, the decline in infant mortality over time. Let me figure out how to do this. HIV/AIDS, which has been a huge success. Decline in maternal mortality in the 24 countries where USAID had, or U.S. government was working on infant and child and maternal mortalities declined by 25%. Malaria, TB have all declined. Fertility rates, Bangladesh, for instance, was 6.3 in 75 and now is 2.3 in terms of ability of families to manage their family size. So it's really been a very good story in many ways. Why? Number of reasons. I mean, for one, the targets matter. So the Millennium Development Goals established in 2000 really made a big difference in really focusing people on particular diseases, on general health engagement. A lot of the improvement has been around national governments and international governments funding, but also engagement of the private sector and nonprofits. There's a great story with a category of diseases called neglected tropical diseases, NTDs, where the pharmaceutical industry has provided 100% of the medicines required for diseases such as guinea worm and elephantitis. And so there's been a great partnership that's had a huge improvement. Many countries have reduced schistosomiasis, those kind of diseases, through that combination. Data and monitoring health has been one of the sectors that's really been quite advanced in their ability to measure results, particularly short-term, but life expectancy, children's lives, vaccinations, and then very good at explaining what they're achieving and therefore getting a lot of support. But that whole monitoring, changing approaches based on performance monitoring. Financing is including recognizing that health is not just a medical solution, it's also making sure the finance is there for health systems, making sure that people have access. As much as the health systems have improved in many countries, I think roads, motorcycles, cars, and cell phones have had a huge impact on improvement on maternal and infant mortality, because women can get to a clinic in order to deliver, they can get access, and so all those other aspects of a society. It's been a persistent effort. I mean, health has been an issue for international donors for decades, and it's been, even though there are short cycles in the way our political system works, there's been a consistent and persistent focus on health, and that's led to results. More recently, there's been a focus on particular diseases, particularly from the U.S. government. PEPFAR, which is the President's Emergency Plan for addressing AIDS, the Global Fund, which addresses HIV, AIDS, malaria, and TB, the immunization and vaccination, so very focused, targeted, disease-driven programs, which really have had a big impact. And some of that has spilled over to building the overall health system. So generally, it's been it's a positive story in a lot of ways. One aspect is money. So this is a chart that shows the expenditures on health and the improvement. So there's clearly a relationship. Now this is individuals, families, governments, and the international community. But you can see money makes a big difference. Where that puts the U.S., and I think it's important for people to realize how important the U.S. has been in this effort. As you can see, the United States is the largest donor by far, even compared to the multinational banks. That has stayed pretty consistent. So our role has been significant, certainly in this is official development assistance, which means assistance from governments. In addition, there are many U.S. charitable organizations, Save the Children, Oxfam, churches, whatever, who have been contributing, which is not captured by this. So generally, the U.S. presence has been quite large in the health sector. It's been growing, the budget. So as you can see, the allocation towards global health has been growing. A lot of that is related to HIV, but again, there's been a very strong commitment from the U.S. in the health sector. Just to give you a sense of what that history's looked like, this is a detailed chart, but just John F. Kennedy founded USAID in 1961, as well as the Peace Corps, which also has some role in the health sector. And there have been a series of different initiatives in health to address the different issues. Population and reproductive health was very early on. That was in part because of the proximity of Latin America and a big focus there with urbanization, growing population. Smallpox, which is had a huge success globally, in elimination essentially. Development changes. It has different ebbs and flows in terms of its focus. So in '73, USA had pillars of down to basic needs, and health was definitely one of those. Then again, looking at issues like diarrhea, the role of vitamin A in long-term health. 96 was really the first focus on systems and looking at accounts and finance and what was going into the health system, with this manual that was used by 100-some countries in order to manage their flow of health resources, financing. 2000 was the beginning of these special funds. Gavi is the Global Alliance for Vaccinations, really focused on improving very early childhood development through basic vaccination. 2003 was PEPFAR. President Bush launched $6.6 billion the U.S. has put into the PEPFAR program to date, and it is the one program that President Trump has said that he will continue. So at least we know we'll continue with PEPFAR. And as you have seen, the whole, whereas when I first started working with USAID in the early 90s, AIDS looked like it would have this devastating long-term impact, and it's now turned the tide, where it really is becoming much more of a manageable and potentially a disease that can be eliminated. 2005 is the President's Malaria Initiative, again, had big success. Then in 2009, with President Obama, I'll get into that in a moment, but just President Obama had launched a global health initiative that was looking more broadly at health systems. So why is the U.S. government so interested in health? One is there is a compassion, or has been a compassion, in the U.S. towards the world, recognizing that health is health of children, health of mothers, health of populations is something that we care about as a nation and part of our values. The Millennium Development Goals and now the Sustainable Development Goals have a strong emphasis on health, and it's something the U.S. has made a commitment to. Beyond that, there's a strong link to national security, which is a driver of foreign policy. So looking at how health relates, very strong correlation between health and income growth, economic development, human development. So if you see countries as a desire to have countries become more economically viable, therefore more stable, therefore a more peaceful world, therefore more safe for Americans, there's sort of a progression which says it matters to invest in this basic life function, and eventually tied to national security. It's also a tie towards pandemics, as we know, with Zika, with Ebola, with HIV, that our borders are not solid, they're porous, and the diseases that are big in other parts of the world have a tendency to show up in the U.S. So very much protecting our population means we need to look across the world. Some of it is identifying pathogens, and I'll talk a little bit more about the role of the U.S. military. But the military, our defense, Department of Defense has both Naval, Army, the different services spend a fair amount of money on collecting disease data in different countries, identifying it as a way of protecting our forces. So identifying pathogens that might affect the U.S. armed forces, but also the future of the American population as well. And to some extent, as the expertise of development of providing government services expands across the world. There are many centers of excellence outside of the U.S., and by having a relationship with those, we too can learn from other countries. Lastly, is the market for U.S. health, corporate interest, health insurance, big industry across the world. We were working on a health insurance regulatory system in India. Happened to be a market for the U.S. health insurance companies to come into. So there is that, and equipment. GE sells a lot of hospital equipment across the world. So there's kind of a symbiotic relation, particularly with the Department of Commerce, but an interest in expanding our own markets. So this is national security. This is the founding of USAID, John F. Kennedy. You see very much a link between the assistance program and a sense of protecting the U.S. interests. Our own security would be endangered and our prosperity imperiled. A program of assistance to the underdeveloped nations must continue because it's our national interest. So that is a very explicit link between assistance programs, including health, and our long-term national security. Again, in 2015, the National Security Strategy identifies infectious disease outbreaks as a major threat. In fact, one of the major drivers behind President Bush launching PEPFAR was the CIA, Central Intelligence Agency, identifying HIV/AIDS as a major national security risk. In some ways, just as an aside, the CIA plays an interesting role in some of these. They have recently identified climate change as a major threat to national security. So in fact, that may be the way that the U.S. gets back into climate change. But where are we today? A lot of diseases are not fully eradicated. Malaria is still killing many people across the world. HIV is still a clear threat. But there is a shift in many countries about where the drivers of mortality are coming from. Increasingly, I just came from Cambodia. There, it's diabetes, it's heart disease that's killing people. These are non-communicable. These are lifestyle to a large extent. More complicated, they're behavior-based. As we know, as Americans, you may know that you should eat better, do more exercise, but not that many Americans do that. It does seem to be changing, but they're more behavior-related rather than disease, than bacteria. And nutrition and malnutrition is one of the major issues. It's been very stubborn in many countries, even though there have been improvements across the board. Cambodia, 1/3 of kids were malnourished. And in countries that are developing quickly, like in India, you have 1/3 of the population is undernourished and 1/3 is malnourished and overweight. And so you have major problems around that. And nutrition is very complicated. It's about access to food, it's about affordability of food, and it's about appropriate use. It's also very related to sanitation. Particularly in Asia, but everywhere, a lot of kids are malnourished because they can't absorb nourishment because they have too much bacteria in their guts. And so you have to address water and sanitation and hygiene as well as health. So you're getting way beyond the traditional health systems. Air pollution, the WHO has said 1 out of 9 people are dying because of poor air. If you read about Beijing, you read about Delhi. One of the great things about having left USA is I live in a state that has clean air. In fact, the U.S. has clean air, and it's just a huge improvement on my own life. Aging population, the world is aging. China may be the first country that will have an older population without having increased their income. Generally, aging population has come with increasing income, and it'll be interesting to see developing countries as their population demographics shift, and a larger percentage of the population is older and not working. And what does that mean for the health system? Mental health, an issue that the U.S. government has totally ignored overseas. Most development assistance programs don't recognize it. Clearly an issue, and as we look more broadly, how is that going to be addressed? They're still chaining people in Cambodia. It's not unusual to find people chained to a tree because they're psychotic and they have no medication, but something that is not being very well addressed. And then the unknown pandemics. Who heard of Zika 15 years ago? Where did that come from? What else is going to come down the pike? So that's the challenges for the future. And then we have these other trends, which have a major impact on how you would address health. Urbanization. We're now, majority population lives in cities. Should be 2/3 will be in cities by, I think, 2030. What does that mean? We've been very focused on rural populations as development agencies, so now we need to learn about cities and it's a very different way of delivering health systems. Climate change, clearly, malaria is creeping into South Africa because of the warming temperatures. Diseases are spreading because of climate change. Changing the dynamics, how does that get dealt with? Conflict, as you can see, that very hard for people to take care of their basic health needs when they're in the middle of a war or they're fleeing a country because of conflict. And then migration, mobility. We hear about refugees all the time in Europe, but there's incredible migration for good and bad reason. Cambodia had major population movements back and forth to Thailand. And for jobs, how do you treat malaria when people are coming and going and also spreading some of those diseases? So all these factors are in there too. So here's sort of some ideas about what needs to be done. Comprehensive systems. So one of the issues has been, I think we've addressed many specific diseases with very parallel systems. There are HIV/AIDS programs that funded people separately. Typically, HIV/AIDS workers got higher salaries than regular health workers. And now in a country like Cambodia, where there are 67,000 people with HIV, which is very small compared to 15 million, how do you integrate those specialized pipelines back into a health system? Especially when you've had a different prestige. If you're working on HIV, it's higher prestige than working on infant mortality. So how do you bring those back in? How do you look at the public servant dynamic, the public employee side of it as you integrate these systems? But really, if you're going to build a health system, there must be a way to need to look at that whole comprehensive system rather than individual diseases. It's an issue with building public confidence in both public and private systems. We had a tragic case in Cambodia where one of our own employees in the health office, and our local employees there were paid relatively well, died because of appendicitis, a burst appendix. His family felt they didn't want to go to they didn't trust the public clinics, even though they had improved substantially over the last 10 years, and they didn't have the money for a private clinic, and he died. By the time people in our office paid attention, took him to a hospital, it was too late. So that kind of tragedy where he would have been treated in a public clinic if he understood that. Part of that is regulation. How do you set standards for the private sector? Many countries don't have a sort of grassroots private sector where people hang up a shingle, I'm a doctor, and they're not. How do you get a self-regulatory or some kind of regulation in a private system? And how do you integrate the traditional providers? South Africa, one of the issues with HIV is many people were going to the traditional healers. Some of the successful programs were working with them to talk about HIV, to talk about the fact that you can't eat turtle eggs in order to prevent HIV, and trying to get the traditional healers to participate in that. Financing, of course, a major issue. You need money, as you saw in the chart, direct relationship between health status and spending money. Where does that come from? How do you leverage the private sector? How do you make sure the poor are included in that, particularly as you look at private sector health delivery as a key component? Lastly, just looking more broadly at a healthy place. What is, to really get a healthy population, you need good air, you need jobs, you need safety, public safety, you need rights of women not to be domestically suffer through domestic violence, all these broader issues, and how do you incorporate them in? So that would be the goal. That would be the sort of seeing a broader perspective. And I think President Obama recognized this in 2009 when he said that in order to address these major diseases, which have been identified as a national threat to U.S. security, we need to build health systems. I think he's very clear and launched the Global Health Initiative that was about health systems. Good principles, and these are, for those of you who know development, these are sort of what you would want to see in a good development program, focusing on the people who have a major role to play, particularly women, clearly relationship between women and child health, countries owning their own programs, looking at long-term sustainability, looking at the comprehensive health system, not just specific diseases, looking at partnerships, leveraging private nonprofit monies, integrating across diseases, making sure they're keeping up through research and the monitoring and evaluation. So a great principle. The problem is, if you look at U.S. government funding, you don't see a lot there currently going into health systems. You still see a disease-driven budget. In fact, much more driven that way, with a huge increase in HIV/AIDS. Some of that money, as we've found, spills over into health systems, but some of it, particularly in countries where the target population is getting smaller and smaller, it's harder to build a health system. Cambodia, again, where it's really, HIV is concentrated now with sex workers, men having sex with men, and drug users. It's not the general population, and so you need a different kind of way of addressing it, which may less spill over into the health system. So it's a bit of a complication. So though the intentions were good, the budget doesn't follow. And I think Tony who's a budget follower, you understand what public policy is, not from what people say, but where they put their money. And so there is still an issue here. For the U.S., the major challenge is sort of how do we keep the U.S. government interested? If the issue now is increasingly less the big diseases that may spill over to the U.S., but more health systems, dealing with lifestyle behavior change, how do you keep the U.S. government, the U.S. public interested in overseas? Again, how do you balance the role of public sector, private sector, and NGOs, and the military? As I said, the Department of Defense increasingly spends a lot of money on health. I was very mixed about it. It was a place to get money for resources. There are a number of different Defense Department agencies who are working in health. But some of them most of them are looking for the impact on U.S. forces, armed forces. And if, for instance, the Naval Research Unit in Phnom Penh in Cambodia, very sophisticated, was bringing in very good equipment to identify pathogens, but it cost $1,000 to run one test. NAMRU, the Naval Research, was looking for the government of Cambodia to pick up the cost of this. Why would they do that? They are having people dying of malnutrition. Why would they run a $1,000 test to identify pathogens? So how do you build in the kind of interest of the U.S. military into building the health systems? And lastly is sort of coordination. So here we have one of the key players in this. Some of you may recognize some of these people. That's Nancy Pelosi. Second from the left. This is a group of Congress people who came to Cambodia looking at our health program and HIV/AIDS. And so Congress has a major role to play in that. These are people, they have individual interest. How do we work with them to make sure that they're supporting a health systems approach? These are all Democrats, by the way, but we obviously have to work with both sides of the House. But these are the key players in the U.S. government's role in health in the future. Lastly, this is just to give you a sense of coordination among U.S. government agencies. This is U.S. Cambodia. not a major country in the scheme of things. And these are all the agencies and sections that we're working on health. So you have the USAID Health Office, you have the Center for Center for Disease Control, CDC, major players, NAMRU, the Naval Research, AFRIMS, which is the Armed Forces Research Institute, PACOM, Pacific Command, which had a big presence working on health, DITRA, which is the Defense Threat Reduction Agency that was funding community health workers. Then you have the U.S. Department of Agriculture, USAID Ag Program because of zoonotic diseases, avian flu being a one people mostly know. Then you have State Department and their environment and health specialists. You have your Public Affairs Office, which is looking to promote U.S. government presence. Peace Corps working on sanitation and hygiene. And so how do you get all these people to work together? They all have somewhat separate goals, though on the tactical level, a lot of them are doing the same thing. So just that process of coordinating all these different interests. Some tools, it's not overwhelming. It might be overwhelming, but it's not hopeless. There are a number of tools. Data is increasingly important as we see that there is so much impact from being able to tell stories, both personal stories, humanitarian stories, but also the results. So getting better measures of health systems. One of the big problems in going from reducing number of people living with HIV or new infections is going to how do you define a healthy health system? And our measurements are much poorer on that institutional capacity side than they are on the disease specific. So really that's a challenge to you all who are interested in this, is how do you start developing better ways of telling a story that are going to get people like Nancy Pelosi or the others in Congress to support it. Leveraging resources, as I said, that you've got, it's not just official development assistance, it's increasingly national governments on their own. You have an international community of private sector and nonprofits who are continuing to work. How do you make them work together? As assistance sometimes looks more like an industry than a charitable venture. How do you get people driving in the same direction? And that's a lot about leadership. And the role of communication technology. I mean, this has made a big difference. How do we use that appropriately? We were able to reduce the diagnosis of TB from 3 weeks to 3 days by using cell phones, sending in the results. How do you use cell phones and smartphones to get doctors to give advice? Very shortage. There's a large shortage of health professionals in many countries. How do you use technology to improve that? So it's not it's a challenging story, but not a hopeless story. So that's where I am. I'm happy to answer questions.
Thank you, Rebecca. Please wait, we have mics come around. Give me one and
And why don't you come and say
all.
Hi, thanks so much for that wonderful talk. I'm a TB physician and researcher, and my question for you, I just wanted to hear your thoughts. So this is something we talk about a lot in the TB world. TB is the single agent infectious agent that kills the most people in the world, and yet we always, our funding is lags so much behind HIV. And proportionally, I saw on your graph that only 4.8% of the budget went to TB. What are your thoughts about what goes into the prioritization of the funding? Because TB proportionally kills so many people in the world and affects so many people, and arguably has a huge impact on national security, however you want to define it. Immigrants and refugees definitely contribute to a lot of the latent TB pool in the U.S., and multi-drug resistant TB is becoming more and more of a problem all over the world.
Well, of course, all of this is my personal opinion. I no longer work for the U.S. government. It's partly of it is HIV got a lot of attention because the CIA identified it as a national security risk. It's fast. It kills the population that's working. It's a huge impact on income. It partly captured interest. It also was much more directly related to the U.S. and national security. TB is a longer-term disease. It's frustrating to people who work in TB. But our development assistance is not coherent in terms of the impact on lives. It really depends on what captured people's interest. So part of it, and having the global fund include TB along with HIV and malaria, which also kills many, young and old in Africa. They don't have the same impact on the U.S. population, is my sense. They've also been more difficult to treat. HIV has really come down because of people infected being put on ARVs, which reduces their ability to infect others. I think TB has been harder to treat. People aren't consistent. They have to maintain, well, same with ARVs, but I think it's been less dramatic in terms of results. But it's, again, the knowledge about diarrhea kills tons of kids. That has led to a focus on water and sanitation. But again, it's sort of getting these things before people. That's why it's important to talk to your congresspeople.
Thank you very much for doing this, Rebecca. This is very, very important for AID people to get out there. I know you've retired, so you can be as much of an advocate as you wish. And it's very important for people to be exposed to the kind of expertise that people at AID have. And I think it's unique in government, even despite the fact that you mentioned all these other organizations. We have a class on institutions in the U.S. government, national security institutions. Many of the class is here because we let them out early to hear you. What I'd like you to talk about a bit is the other organizations that do health work and compare them to USAID. I think you've already made a very good point about the interest that AID has in health systems writ large. But CDC, for example, its main mission is more to protect Americans from diseases, infectious diseases that might come here. You've already mentioned the military as having more interest in protecting their people based overseas. The State Department, I still to this day do not understand why PEPFAR is under the State Department, which works with HIV/AIDS, and of course the old debate about whether we're spending our money on prevention or treatment and how that comes out in the end, especially when you have a zero-sum game as we have today with huge budget cuts coming down the line from this administration. Could you talk then a little bit about why USAID is unique and among government agencies that are working in this field?
Thank you. Good to see you. Well, it's obviously a political world, and I remember when Colin Powell was Secretary of State, and one of his goals was to put other U.S. government agencies back into their role of working in the U.S., and he failed miserably because everybody else wanted to work overseas. In my mind, USAID is the only agency that were part of the national security, the foreign policy, American foreign policy system addressing national security, but the objective of USAID is to build healthy populations in other countries. That is the goal. Whereas all these other agencies, as you said well, have other objectives behind them, and they may contribute. The Centers for Disease Control, which is why PEPFAR remains in the State Department. I'm not a health person by background, so I only know this from watching it a bit afar, but there's been a very unpleasant battle between USAID and CDC around HIV/AIDS in countries that sort of, from our perspective, CDC sort of jumped up and started to demand more funding. I think from the USAID perspective, they're technicians. They mostly hire doctors. Not that there's anything wrong with doctors, but public health and medicine are not necessarily the same. We're talking a lot about behaviors, certainly in HIV/AIDS. So understanding that dynamic and hiring public health specialists who understand the interaction between medical solutions and behavior change and politics and institutional analysis. And I think that's where USAID is quite different, because we do have a lot of highly qualified health people, probably the most now in agriculture. We also have a lot of doctorates and specialists, but there's been a recognition that it's not a medical solution. So I think that makes us quite different in CDC in the way that we operate and the attention to health systems. There is a very strong and dynamic head of the PEPFAR program, Ambassador Birx, who comes out of the CDC world and has very focused on results. And what's missing from that is it needs to be part of a health system. You need to address people and you need to get access to people vulnerable to HIV or living with HIV through systems other than just clinics. The military clearly has money. Some of the agency, like DITRA, which is Defense Threats, they have money. They didn't have a clue of what to do in health. They knew what they wanted to do, which was to identify pathogens. So they came to us. They came to USAID and said, what should we do? And actually worked very well because they really didn't have any expertise in health in other countries. And so we said, well, why don't you work with these laboratories and help build them up? That helps you, that helps us. So in that case, where you had an agency that really didn't have any expertise in the field, they were more willing to work than that. I don't know, I guess if USAID goes away and gets put into the State Department, it won't matter. I don't know if some of you saw in the news today, there was an article about USAID being incorporated into State Department, which has been a long-term debate. And I have a very strong opinion about why that's not appropriate. Our view is very different. Overall objective, goal is the same, but our view of how you get about development is quite different from a 6-month time horizon. But we'll see. So I had a very good question. I wish, just to give you a flavor of how nasty some of these agency battles can be, in Burma and Myanmar, there was no HIV/AIDS program for 1 year because the two agencies could not resolve, mostly Washington based, not so much in the field. They could not resolve the division of funding between, I'm embarrassed to have to tell that story, but it was true, between USAID and CDC. So we're, agencies have the same bureaucratic problems they do everywhere. A lot of turf fighting. I don't know Brian, if you have anything more to add from your perspective, having watched this.
I have so much to add, but I don't want to talk later.
Your last comments were actually a good segue to my question. I'm Ashley Levette. I'm a PhD student in the School of Public Health here at Brown in the Department of Behavioral and Social Sciences, so thanks for the shout out earlier. As you mentioned, this whole division by disease types or health areas, it's not necessarily unique to US AID. If you look at the National Institutes of Health and the way that the institutes are divided up, it seems very not integrated. And so I'm wondering if you think it's viable, if it's possible for us to integrate on the global scale if we are not integrating the health systems within the U.S.
I mean, the other piece I think is really important is the field presence. And so as you saw that chart of the interagency health program in Cambodia, it actually was a lot easier to have a coordinated strategy in the field because you're working together, you're in a real place. A lot of the battles, turf battles, happen in Washington. And so those may not go away. I think even if, AID becomes part of state, it's not going to go away. There's still going to be battles for bureaucratic reasons, but at least in the field, and the stronger the governments you're working with, the stronger the Cambodian government was in saying, there was one of the reasons that Cambodia is maybe the first country to eliminate new infections of HIV is they had a very strong Cambodian leader who was focused on HIV. So the stronger those governments are and the more accountable they are, if they're their own people, they're better they are going to be at coordinating international assistance. So I think that's a big piece of it. And again, a good development science is you strengthen the countries you're in and their government systems, and you respond to them and you help them do what they want to do to a large extent. And then that leadership is how you get coordinated. And it did bring some of the agencies into line because the health ministry was saying, we don't want you to do that, we want you to do this. And it's like, oh, okay, then you have to do it. So that, and from an international assistance perspective, that's the way. In terms of eliminating bureaucratic infighting, I don't know what the answer is.
I'm going to two-finger on that. And you mentioned the struggle in India with the private insurers, and I'm wondering whether there's a clear preference in the debate over what it means to strengthen healthcare systems with respect to single-payer systems or systems that use private insurance, and how we come out on that, and whether it's hard for the U.S. to play a leading role here precisely because we don't do it at home.
I think the good development professionals are very conscious of that and not trying to dictate U.S. policy. Many countries have their own ideas. They're getting ideas from other places and supporting them in the data and the research behind it rather than expressing an opinion about this is the way you have to go. So I think that was more of the, certainly in India, which had a very sophisticated public administration force that was very involved in development assistance, which was a tiny drop in India, but actually I think quite influential because we did provide the kind of expertise that was being looked for. So getting away from those decisions, because every country is going to be different on where they are. And some of them have embarked on much more sophisticated systems than they really could handle, which I think has backfired as well.
Other
Just curious about the vaccination program. How are you doing with what seems to be, a solution to a lot of disease? And then I read that Italy has a real problem with measles because they've stopped vaccinating, or a certain portion of their population stopped vaccinating. And I'm just wondering what happens in a third world with vaccinations, and if this is the message.
U.S. aid itself doesn't do vaccination. It's really the Global Alliance. So it's providing those resources. I think it's still a priority in maybe because in developing countries, that status hasn't been reached where people think it's no longer a problem. But it's also, polio's been a big problem in India because some populations were afraid of the vaccinations, and that's taken a lot of, and didn't help very much when it was polio workers that was used for the Osama bin Laden attack. I mean, that's sort of being a little more careful about how we use our national security interests not to undermine health systems. But I think my sense, and again, I was managing at a high level, is that emphasis on vaccination is still quite strong in the less developed countries because they haven't gotten to that point. But there are complications with all of these things. But just on vaccinations, that's a piece of it. But if people don't lead healthy lives, don't have access to water, I mean, there are a lot of other reasons why vaccinations is not the only answer. And so that's why it's important to have the whole system in place.
Maybe I'll ask one more question about the narrative issue. And I mean, the problem with saying that the U.S. wants to build healthcare systems or strengthen systems is it sounds an awful lot like nation building, which we have an aversion to on the one hand, and then on the other hand, a lot of the emphasis on behavioral change, cuts at cultural issues that are very hard to resolve anywhere. It sounds like you need this bizarre combination of medical anthropologists aligned with systems builders. And I'm wondering whether that's been an explicit line of development within aid. And if not, are other people doing this in a way that makes sense, sort of pairing medical anthropologists with system specialists in thinking about what it means to move forward in any given place?
I haven't heard of medical anthropologists becoming part of the scheme. I think what's happened, particularly with issues like nutrition, is it's crossing sectors because you're talking about food, so you're talking about agriculture, you're talking about water, so you're talking about the water people. And so that mix has brought in a new approach. I think one of my pieces of advice is to make sure that we're talking about reality. World Vision did a 5-year breastfeeding program in Cambodia that had 0 results. And it was that got a lot of play among the development community because it was very important. We think it's automatic that women will, if they know, they'll breastfeed their kids. Well, women are just beginning to get into the workforce. There's a lot of mobility. There's a lot of migration in and out of rural villages. There's a lot of market access to bad food that's much easier for mothers to give. And so recognizing that this stuff, there's a reason why people aren't doing this. It's not necessarily that they don't know. And so that tendency to get away from what should be to what is is something that I think hopefully we're getting better at, but there's still a lot of, this is the way it should be. If people know, they will act. Well, we know that in the U.S. that doesn't work. We know a lot of things that we should be doing that we're not doing individually, and getting more to that approach. So I think having this cross-sector does make a big difference, because you get these different views, and then that forces a recognition. So I think my sense with USAID is that our health professionals are not medical approaches. There are very few people who really see that, that they're public health professionals. And so that's part of it versus, to pure medical.
Hi. So you talked about very briefly about capacity building, about kind of USAID going in and working with local partners. And I was just wondering if you could talk a little more about that. What are the mechanics of that, and what are also the results you've seen, rather than just coming in and setting up a hospital and running it yourself, or however that works, versus kind of building that capacity within the local community?
Whether there has been in countries that have relatively good governance systems, the U.S. government does transfer money directly, so budget program support into government systems. That's a little more compromised. In Cambodia, we didn't do that for a variety of reasons, but that's where you're actually helping the government directly by funding them, and a lot of the donors, particularly the EU, do a lot of budget support or sector-based budget support, so they're just providing it. It's really working with the way we worked in Cambodia and in Mali was working with the health public servants and providing training to them, providing data. We didn't buy equipment, we didn't run hospitals, we didn't run clinics. We supported some local organizations that they themselves provided technical assistance and training to the government's health workers. And the private sector was getting the private, some of the better private providers together to start talking about regulatory systems that they themselves would do. So it's really supporting the people whose job it is to do that, rather than creating a parallel. There is a problem with countries like Cambodia that come out of conflict, because there's this wealth of compassion and NGOs and charities that go in. I think in the 90s, there was hardly any public health system, and it was all being run by nonprofit organizations. And I remember talking to the AID sort of health manager, and he came in, he had literally had to fight to have space for the government to get back into health. And so that's one of the problems in a lot of the conflict countries, is you've got this massive, you need immediate assistance, but how do you back out the NGO sector and allow the government and the private sector to take their appropriate roles? But it was interesting, in Cambodia, there was an organization that had been part of a international contractor, and it then became a local institution. And they're all Cambodians, and they provide this technical assistance to the different organizations working with the government's health system. So that's the ideal, where not only is it not only is it working with the Cambodian system itself, but the people providing the assistance are Cambodian. And I think that was the big success in Poland. When we left, our goal was to create Polish consulting firms and Polish public policy institutes that could do the work that USAID had been doing with some of its advisors. Not very popular with the U.S. contractors, I would have to say. And I give a lot of credit to the ones who had the same vision, and they were mostly the nonprofit ones, to really work yourself out of your job, which is what our job is, and then getting our partners to have the same feeling that their job is to get out of the way and let the countries do it themselves. So that's the approach, so we can leave. That was my goal in Mali, and just to comment on that, it was the first country I worked in, because I had been in transitioning countries where it was truly development dependent. And my goal after a few years was to get the government to envision a day when they no longer wanted development assistance. And the Minister of Health said, "Why would you want to leave? We really like you." And it was so depressing. So I think, and that's our collective fault, I think.
I'm going to ask one question as the career counselor that helps some of these students, noticing that there's a lot of students in the room. And as you mentioned earlier, you've had in the past many questions about careers, and especially as the landscape changes, I'm wondering if you have any advice or recommendations for what you've seen as the most important skill sets and certain avenues that you see there's most need for, future career paths?
Well, a very gross generalization is skills, communication, strategic ability to develop, to think strategically, curiosity, engagement, being able to work with teams, being able to work with other partners. I mean, those are just the basic skills, which frankly, when I hear from the people involved in hiring in USA, that's what they're looking for. Bottom line is teamwork, engagement, willingness to go out. So that's just across the board, and you can do that through all your respective programs. But that's strategic approach. Also basic, data, understanding the use of data, monitoring and evaluation. We trained. We worked with the School of Agriculture in Cambodia on monitoring and evaluation, and I have never seen more excited. I was really astounded. Professionals, they were all in-service officials who had learned how to go out and monitor their programs, and they were so excited. They said, "This is great. We can go find out what we're actually doing." Anyway, those kind of skills are really important. In terms of specific, international assistance is a big world, maybe too big of a world sometimes. U.S. government, I don't know what's going to happen. Clearly, we're in a period of sort of downsizing rather than increasing, though hopefully there'll be an ongoing engagement. As you saw, the U.S. is really important in global health, and that'll continue in some way. So there, in terms of USAID itself, the health professionals all have at least as Foreign Service, all have at least a master's in public health or something related, and have had some experience. I would hope that experience includes community work in the U.S. or work on pueblos or reservations, not just international, but the moment's biased towards that. So that kind of technical aspect. You have this wealth of nonprofit organizations, Save the Children, Oxfam, that'll continue. In fact, some of them are getting a lot more donations now. And then you have the private institutional contractors, the Chemonics that all do health. And then you have the corporations, you have insurance companies, you have GE who are looking for health professionals. So there's a whole range, even if the U.S. government, at least for a while, doesn't hire so much. There are a lot of other ways to get involved. And then working directly. Increasingly, governments are hiring people directly. And in some cases, U.S. expertise is cheaper than local expertise. It's interesting because things are changing so much in the world that some countries are paying their public employees much higher than we do. So an American will be cheaper, which is a very interesting change. So I believe that sector, I'm not a big fan of sort of generic international relations. It's sort of having a sector base just because you can understand it much better in the dynamics if you're really focused on one area, even if you then transition over. It's my personal bias. But that mix of general communication, teamwork skills, plus some technical, and then reading what's going on. It's going to be an interesting world, a lot of new challenges coming.
There's time for one more.
And I'm going to take it.
There is a hot button political issue that I'd like you to address, realizing that you're probably not instinctively wanting to talk about political issues, but this one relates to global health and the ability of AID to work with local NGOs and others, and that is the Mexico City policy. Basically, we are trying to extend our own values to other countries, saying that if you are any way involved in advising on abortion or doing it, even with someone else's money, we can't work with you. To what extent is that really constraining what AID can do on all areas of public health?
Well, as you know, this has been an issue before. We've been under several administrations. It's bad. I mean, there's no question that it really limits the ability to work with some very effective institutions who do a lot of other stuff, but primarily do a lot of other stuff. I think it depends from country to country and how many resources there are. I think one thing that USAID learned is we can swap funding And we've done that in certain countries where we were supporting an institution, we can't anymore, and so then we support something that the Swedes were supporting, and then they pick up what we were doing. And that has happened effectively, and I think that's kind of an interim gap. There is also a private, I think donations are flowing into Planned Parenthood and some of the organizations that will continue through. I think the private funding is just going to have to pick up some of this. I mean, it's clearly a lot of these organizations provide our comprehensive services, and all of those are lost. But part of being a good development professional is figuring out you have money for this, and how do you use it for something else? And not illegally, but just how do you make it work? And I think that's increasingly, I don't think our budgets are going to be growing. Our budgets for general development, apart from working in Iraq and Afghanistan and all those countries, I don't think are going to be growing much in the near future. And so how do you become more clever in using those resources that you do have? And our Congress, which is very important, is also intimately involved in the details of foreign assistance. So we have advocates for child mortality or maternal mortality or water, and they're very earmarked. And so it's always been a skill of how to see beyond that and say, well, our goal is this, and this is how we put together a program that addresses it, whether you swap with other people. I also think this partnership, the U.S. government is very important in health, but there are other actors, and it's really figuring out how not to compete with them and how to collaborate with them. Because we also are representing the U.S. government taxpayers, and taxpayers want to get credit for it, there's always the U.S. is not very receptive to putting money into a pooled fund where it's blind that the U.S. government is there, but there are ways of finessing that as well. So I think that collaboration, which is also a big skill that USAID is looking for, is how do you work together and pull the same direction. So it's not ideal.
Well, thank you, Rebecca. This has been wonderful, and big round of applause.